Changing trends in healthcare mean providers need to consider how to best deliver value to their patients. For a healthcare provider, delivering value means improving patient outcomes at the lowest cost. However, a few healthcare executives have taken advantage of the tremendous opportunity that is offered by real estate and facilities in their strategy for survival. A strategy for competing successfully in the new world of risk-based payment models includes optimizing real estate, space utilization, facility maintenance, and building renewal. Today we are joined by Johnson Controls Global Workplace Solutions for a candid interview to uncover and discuss the impact of enterprise facility management on healthcare's value equation. Johnson Controls Global Workplace Solutions is a leading provider of integrated facilities, corporate real estate, workplace, and energy management. They create business advantage for their customers through tailored solutions that optimize customers' real estate performance and employee productivity while reducing total occupancy costs. Johnson Controls Workplace Solutions' 17,000 employees ensure the business continuity of over 1.8 billion square feet of real estate in more than 75 countries. Specific to healthcare, Johnson Controls Global Workplace Solutions helps lower operational costs and heighten regulatory readiness so hospitals can focus on the core mission of healing patients. I'd like to welcome John Summers and Todd Seipel from Johnson Controls Workplace Solutions. John is Vice President, East Market Unit with over 21 years of experience in the real estate, facilities, and energy markets. Todd is an account director and brings more than 28 years of facilities management experience with the last 12 years focusing on healthcare. John and Todd, thanks so much for joining us today.
Thank you, Molly. Looking forward to it. And good afternoon, good evening, and good morning for those of you joining in other parts of the world today.
And thank you, Molly. I look forward to our conversation today around healthcare facility management.
Great. Thank you again. So, John, I think we'll start the conversation here. Enterprise facility management outsourcing is a fairly new practice to the healthcare industry. Maybe you can start by just describing what outsourcing means in general.
Yeah, no, I'd be happy to, Molly. So again, what we're going to describe today is just some general macro trends we see going on in the marketplace and a couple of ideas that we, I think in the supplier marketplace in general, have brought as a proposed solution. So let's kind of start at the top. So when we talk about outsourcing, in many cases, it's not new from a facilities and real estate perspective in the Fortune 100 or Fortune 500 space, but in some cases we're starting to see continuing trends in the U.S. healthcare marketplace. And so many of you that are on the phone today have experienced some form of outsourcing as it relates to IT or other shared services. What we're going to explore today is really how we see the trends around facility management, real estate, and projects growing at a, if you will, exponential rate in the U.S. healthcare space. What you see in the slide in front of you is really the main drivers as to the why. Again, not necessarily specific to just healthcare, but the general reasons why real estate leaders, corporate leaders, business leaders in general will move to an outsourced model. And the drivers, again, are reducing operational expenditures. In many cases, again, the process performance that you can have by moving these types of services, non-core services, to a supplier, given the fact that the supplier repeats those processes on a much more significant scale relative to the volume, provides some benefit. And then again, from an economies of scale standpoint, ranging from IT platforms all the way through supplier management, those efficiencies typically are at the top of the list in terms of why executives would move to an outsourced model.
Great. And then, so what type of outsourcing trends are you and your clients observing most, John?
Sure. So the slide that you see now is really a depiction of the types of models that organizations have selected to deliver, again, those core services as it relates to facilities, real estate, and projects. So the one question I'd ask of you, for those of you joining today that are an end user, is where do you find yourself today on this spectrum? The marketplace has really evolved from Model 1 to Model 6. And so I want to give you a couple of endpoints as it relates to the variations between the two, and in my observations in terms of where I see the marketplace today. And so model one is a very traditional model where facilities, real estate, and projects are managed in-house and done through, if you will, in-house teams, but under separate delivery organizations. So very much, if you will, an in-source solution. Model 6 would depict, if you will, the far end of that spectrum, where the client has integrated their in-house strategy and delivery team into a single unit and provided, if you will, the sets of services around those three scopes of work to a single integrated provider. And so those are really the two ends of the spectrum where we would see the U.S. healthcare marketplace as an example. For the most part, it is really around Model 2. So they have, again, separate in-house management teams, a dedicated team around facilities, a dedicated team around maybe capital expenditures and projects, and then a real estate team. And then using a multitude of in-house as well as out-tasked supplier models to get the work done. The trends that we see right now, and again, this is a conversation about there's not a right model, but if you will, a journey that we see the marketplace continuing on, is in a number of cases clients are trying to evolve from Model 2 somewhere towards what I would describe as a variation of Model 4, right, where they've integrated and joined up their in-house team, right, so see the total cost of ownership of real estate into a single organization, and then have gone to the marketplace and chosen what I would describe as best-in-class providers to deliver those various scopes. So a world-class leader in facilities, a world-class leader in real estate, and, if you will, a subject matter expertise in projects. What you see occurring in the supplier world is that the scopes of services depicted there are becoming more and more core to a single supplier. So as an example, Global Workplace Solutions would have the capabilities to deliver across all three of those. And in some cases, we're starting to see the model evolve to Model 5 or Model 6, where a single organization would look to place that responsibility to deliver those outcomes through a single organization. So again, the takeaway from this slide is, where do you see yourself today? What model do you want to potentially evolve to? And I think it's really incumbent upon the marketplace, ourselves, your peers in the marketplace, to discuss the strategies in terms of how you evolve from one place on the map to the other.
Great. So real estate comprises 40 to 50% of health systems assets. So a lot of value can be derived from these facilities, and outsourcing is an opportunity to let focused providers kind of take care of those facilities' function by applying best practices and standards from other industries that have similar footprints and challenges. John, what can healthcare learn from those other industries? What are the benefits of facility management outsourcing, and what can outsourcing bring to healthcare?
Sure. No, I think ultimately the first two slides have to be put in place to solve a business need. And so when we sit and have conversations with executives such as yourselves, these tend to be the sort of macro issues that you're dealing with today. One is obviously a continuing pressure, macro pressure in terms of reducing operational expenses. Some of those are legislatively driven, some of those are just market driven. Number two is the expansion of ambulatory care. So the footprint in terms of the types of assets that you're managing today is continuing to evolve. And then number three, the changing business models. So the continuing pattern of mergers and acquisitions within various organizations really changes the footprint, not only in terms of the types of assets, but more importantly, the number of assets you have. In many cases can vary and fluctuate significantly in a given year. So those tend to be the macro problems that our clients are facing. And so when you start to talk about facility management and real estate outsourcing, what we see is that the first impact in terms of solving the problem around operational expenditures is some target typically over a 5-year period of a gross savings in somewhere in the neighborhood of 20%. That's then again done by some of the things that I described in the previous slides. The second problem is really much more addressed what I would describe as a consultative approach to managing the space and the assets that you currently have. So as the needs of the healthcare marketplace change, how do you repackage, repartition, reuse the existing assets in such a way that it meets the needs of a changing demographic and the changing needs that the healthcare provider is ultimately taking into the patient environment. And then the third is, again, something that we don't see at this point in time slowing down, right? So that the acquisition of practices, the integration of platforms, if you will, across various healthcare networks will continue. And ultimately what we're describing here is a real estate strategy to get your arms around what's the assets that I have, what assets do I need, and how do I best modernize those as we go forward. What we're going to talk about today then is if those are the macro issues taking place in the healthcare market, what are we doing or what are we seeing organizations do to offset those? So I specifically addressed 3 areas at a high level. Today what we're going to do is take you through each one of these in more detail. So how do you transfer and lower operational risk? How do you reinvent the care setting? How do you look at analyzing leases in terms of getting your arms around, again, the footprint that you have, more importantly, the footprint that you want? And then 4 and 5 are really around how do you look at your existing asset from a monetization standpoint, and quite frankly, in some cases, as a revenue opportunity for the organization. So I'm going to walk you through those in more detail, but I thought, Molly, what it would make sense is maybe before we do that, we can give some specific examples in terms of what's taking place.
Absolutely, absolutely. So before we get into those examples and some scenarios you've seen with clients, Todd, maybe you can provide some specific examples of realized gains from outsourcing too.
Sure, I'd be glad to. And as John mentioned, a lot of pressure for cost savings are reaching across our healthcare organization. So that's clearly one. We see that both in the short term, the operational expenses, and many times we can find the short-term savings, but always in a long-term arrangement for both operations and CapEx through preservation of assets and sound maintenance practices. Some other areas are around energy reductions associated with operating procedures and capital investment in newer, more energy-efficient equipment. Combining energy considerations with the capital plans just makes smart sense today. Accountability for work order completions. Nothing worse than the hospital CEO having the directors lined up out of his office complaining about the work that's not getting done with multiple requests that just seem to evaporate and no accountability towards getting those finished. With an outsourced provider, you're going to have KPIs that are going to measure your success rate on achieving those work order completions, and certainly the feedback from the customers around customer satisfaction surveys on how well you're doing, and positive feedback and areas for improvement for your staff to improve upon. So it's around the quality of work, the completeness, and providing that caring, compassionate service excellence to the patients, the families, and their staff. So we've seen increased patient satisfaction scores as a result of some of the KPIs that are driven by the customer for their desired goals, and regulatory readiness. We've got a pretty good model for delivering regulatory readiness around life safety, utility management, and support to emergency management, staying abreast of all the Joint Commission and other regulatory agency requirements. But most importantly, it gives the client the ability to focus on their core mission of healing patients and let the outsourced provider focus on their core business. So it kind of depends on the maturity level or the complexity of the existing client's organization. In the first case study I'd just like to share, I'll call this one the status quo. It kind of started out, if going back to John's model, it started out as a combination of models 1 and 2 with separate management teams with a combination of in-house maintenance and out-task project delivery, and then kind of moving more towards that model 4 or 5 where it's an integrated management team with an integrated outsourced delivery. There's some exceptions in the model, but very close to that. A client that had previously not focused on opportunities to reduce their facility management costs, and a first-generation management outsourcing. Clearly, there were lots of opportunities for standardization across their portfolio. Each hospital managed their own facility department a little bit differently. Standardization brought not only savings but some standard KPI measurements and some savings to the organization with standardization. Right-sizing the staffing through attrition, not necessarily through layoffs, but waiting for folks to retire. Better management of overtime with work order management, priority system, OT approval process, really validating the need for the overtime versus just doing everything with overtime. And then, as John mentioned earlier, really leveraging consolidated suppliers for scale and savings for their materials and their contract purchases. So that's what I would call the kind of the status quo. They haven't really looked at their organization in the past and focused on much opportunity for cost savings. And so the next one I'd like to talk about is more towards, the second one is more towards what I call the be-all, end-all. This client was basically a Model 1 separate in-house management team with in-house delivery that moved to a Model 4 with integrated in-house management team and outsourced delivery. They had in-house technicians for construction. They had maintenance repair technicians. Not a lot of sharing of those resources. And when you have projects that are a little bit cyclical in nature, there were a lot of downtime for those employees and a little bit non-productive work. So we really changed that to a core maintenance repair team and then outsourced the projects and renovations on an as-needed basis with contractors, so we're not paying for those in-house wages during the project down cycles. They also did everything asked of them by their hospital CEOs. Again, very driven individually by the hospital CEOs versus the system, so not a lot of standardization. But it was at the expense of maintenance and repair and customer requests and asset preservation. So when they got asked to go do special projects for the CEOs, it was exciting. You could see the progress on a daily basis. The projects got the attention of administration. It was very visible. So it was a pleasurable task to be assigned to, but it was a lot of times at the expense of preserving the assets and doing the maintenance and repair that was needed. We kind of overcame that with clear scope definition, effective KPIs focused on the organizational goals around completion times for our work orders and preventive maintenance. The other area was there was really no work order tracking. As I mentioned, the hospital CEOs said they had directors lined up outside their office talking about unfulfilled customer requests and backlog work orders or just lost work orders. And service providers will provide that accountability for work orders from request to completion through the customer satisfaction survey process and then feedback to the staff for improvement opportunities. This client also was very reactive on their capital replacement. When it broke, they were looking at replacement, probably paying a premium for quick delivery of the asset or the equipment replacement. Not a real long-term capital plan. Had a lot of equipment that was aging beyond useful life, some redundant equipment that failed in place and not replaced, and clearly unexpected equipment outages. Really worked with the customer to develop a 5-year facility infrastructural capital plan that was prioritized and basically renewed on an annual basis, but gave them that outlook for the next 5 years. And the next study is around a customer that really had focused on cost savings in all their departments, and they actually cut, I'll call this the cut to the bone facility services. So this customer, when we went in there, the staffing was not right-sized for their different hospitals. It was very lean, but it wasn't right-sized between the hospitals. A lot of preventive maintenance that was not getting completed, a lot of repairs that were getting Band-Aids versus complete repairs. They really started out in the Model 1 to 2 with separate management teams with a combination of in-house maintenance and out-task project delivery, and truly moved to a Model 5 with integrated management team with an integrated outsourced delivery. The message here is that most of the client's management team usually becomes more integrated to match the service provider's integrated model, which then requires fewer resources, definite cost savings, and some synergy with those departments working together. In this model, we did leverage national suppliers and consolidation for material and contract savings. We reassigned and re-leveled the staffing between the hospitals to truly measure industry benchmarks on technicians' square footage per technician, and again, push standardization between those hospitals, and ultimately created a capital plan that would get them through year one, with working through year one to a model that got to a 5-year capital plan for the customer. Go to the next slide.
Great. So Todd, you have a lot of experience with your clients and a lot of things to draw from. I guess from the accountant perspective, what do you think works well in an outsourcing partnership and some things that don't work so well?
Well, first, you can read the list of what works well, and truly it starts with the partnership. But I guess maybe some highlights of what does not work well might be more appropriate. And in this area, it's really around the client not changing their previous behavior in the way that they manage the employee. Managing a supplier, give them your goals, let them accomplish it in the way that the organization, the supplier has the expertise. Let them do the work the way that they plan. Don't get in there and micromanage it the way you managed it when it was your in-house workforce. So I guess that would be number one caution. Number two would be keep your key performance indicators truly focused on the organization's goals. And this should be no more than 2 handfuls of key performance indicators that are truly focused. And those can change over time. As you get your preventive maintenance program where you're hitting 100% or 98% every single month, that one could drop off as a key performance indicator. Not that you're going to drop off on performance, but one that you don't need to look at anymore with your customer. And you can add some new ones that they would like to evolve to with their organizational goals. The key is really aligning your contract for mutual goal success between the supplier and the customer so that you've got the same risk and reward model for success of the contract.
Great, great. John, how about you? What suggestions do you have for the audience specific to facilities management outsourcing?
Yeah, I think this is where we're going to take you through each one of the headline strategies that I talked about before. I think the message that I would want to send here is the blueprint that we're going to describe has been traversed by, if you will, the corporate real estate world for the better half of 20 to 25 years. So these models, if you will, are in place. We respect the fact that in some cases the healthcare industry is getting their arms around it, or there's certainly going to be some nuances from a regulatory, from a compliance standpoint that we need to be cognizant of as we enter into them. But the strategies that we're going to outline here again are things that have been put in place not only in the healthcare industry, but for many years within the corporate real estate world. And so again, we're going to talk a little bit about how do you lower OPEX by transitioning and transferring operational risk. How do you reinvent the care setting as it relates to repurposing your current assets to meet the needs. We want to spend some time again taking a look at, do you have your arms around your lease portfolio and more importantly a strategy in order to deploy against that. And then there's some, if you will, monetization strategies that we would want to talk about as it relates to taking a look at your existing assets and how do you redeploy those. So Todd, why don't you take us through a little bit of a deeper look in terms of the OPEX side of the equation. Next slide, Molly.
I'm sorry. Thanks, John. So the costs are broken down into kind of 3 areas: the labor and the personnel costs, the material and supply costs, and utility costs. And when you look at the personnel costs, that can clearly be one of your larger categories. And right-sizing the staff and deploying your staff effectively to minimize overtime costs, looking at your work order priorities, managing to those priorities, and then looking at your model of how you're supporting the campus and how you're supporting multiple hospitals. A lot of services can be site-based out of the hospital to support the campus, but then they might have remote clinics that you need to set up truck-based routes with your mechanics to effectively address their preventive maintenance and their repair needs on those outlying sites. So you can look at hub and spoke where you're dispatching out of the hospital and going to a remote area, or you can set up routes around the area if they're very dispersed. Certainly around centralizing your purchasing to procure materials and supplies. Again, you're looking at volumes. You're looking at better discounts through volume purchasing. Consolidation of vendors, less handling of invoices in the back office, and quite a load off the customer because you're taking that away from their accounts payable and their purchasing department. So you're, in essence, helping the customer reduce their resources needed for managing the plant ops function. Clearly around standardization is another area that we see, especially on multi-hospital systems where they're typically run by each of the individual CEOs and don't have a real good standardization plan on maintenance and repair practices and even in work order priorities. So just standardizing that and applying good maintenance practices will get you a lot of cost savings. And then around energy efficiency, anytime you can build that into your capital plan or automate or put controls in for energy efficiency as part of your operations or part of your capital expenditure program, you can see some real reductions in your utilities.
And Todd, health systems today are just made up of so many diverse care settings and types of facilities. So maybe you can talk a bit too about how global workplace solutions can impact facility types.
Sure, I'd be glad to, Molly. So if you kind of look at the graph and you look at the upper right-hand side with what I'll call the high acuity and the high cost area of large hospitals, lots of services, there's a greater scale there for operations, maintenance, and repair savings. You've got site-based technician resources that can support that hospital, but also the campus, the buildings surrounding it, and perhaps the whole portfolio from that large hospital base. Again, project management support that's either dedicated if it's large enough, or a variable resource depending on the volume of the capital projects and renovations that are occurring during the year. Certainly can leverage project management technology for entire system project tracking, also for team collaboration. Kind of in the center of the bullseye there, in the center is the clinic area, which is really about a dispersed portfolio. And there's opportunities, as we mentioned earlier, for improved leasing and real estate solutions. Again, optimizing that footprint to match the mission and services versus putting the services in a building that doesn't match the footprint or the mission, and figuring out what to do with those resources when you change those services and move them to somewhere else. So, again, opportunities for subleases, opportunities for different real estate strategies. The clinics, typically right now, it's a better customer access than a hospital setting. So a lot of folks are moving those non-core, non-acute departments out of the hospital into more friendly customer access, even strip mall locations that are easier. But again, that's getting into more leasing and real estate solutions that need to be brought to the table. In that dispersed portfolio, you've also most likely have the opportunity for variable project management resource utilization to support that distributed facility renovation projects and tenant improvements. Again, it's kind of a when needed, as needed model. And certainly from a maintenance repair standpoint, you'd want to look at a truck-based technician solution for addressing your preventive maintenance and your repairs to that distributed portfolio in the clinics around your area.
And John, how about you? How can enterprise real estate platforms provide more value to healthcare organizations?
Yeah, Molly, it's a good point. So when you think through the three elements that I described relative to the scopes of services, when we talk about integrated facility management, they tend to then deal with facilities, real estate, and projects. And so each one of those typically has, in some cases, their own suite of software platforms. In some cases, we see none at all, right? And the challenge becomes as you start to look across the enterprise of how many different instances of a CMMS platform do I have, or in some cases don't have at all. What is my consolidated look as it relates to my real estate and my projects portfolio? And so the challenge that we experience, dealing with, systems that range from as small to 5 or 6 assets to organizations that are dealing with close to 100, is the complexity of systems that either A, don't exist or don't integrate. And so the first conversation we would want to tend to have in terms of supporting an organization is around how do you put the proper tools in place where they don't exist, but more importantly that those tools, right, begin to integrate and talk to one another. So what you're seeing here is a depiction of somebody at an enterprise level would have the ability to go into their organization, right, and drill down to a particular site or particular location, understand, is it leased, is it owned? If it's leased, when are the leases due? How do I consolidate and coordinate those leases with various other entities within the organization? How many ongoing projects do I have at a given time? When are those projects anticipating completing? What's my capital spend associated with those? And so again, this is the heads-up display that we're really asking for our organizations to think about putting in place. And there's a variety of different tools, some of which are proprietary to our organization, some of which are, if you will, available in the marketplace broadly. But as part of an integrated facility management, you'd want to put these tools in place at a facility level for sure. You'd want to take a look at the value that you could drive by putting those tools together at an enterprise level. And then the question really becomes, do you necessarily want to be in that business? So i.e., do you want to purchase software and licenses, or do you want to look to, if you will, outsource not only the application of the software, but the program management and the operation associated with it? So when we talk about ways that technology can improve spatial utilization and uncover savings, it's really in those areas of what tools are in place today, how efficient and effective are they? Are they integrated across, if you will, the enterprise being, again, those 3 areas: facilities, real estate, and projects? And then ultimately, what's the value in the data that they're providing? So if the data, if you can't interpret the data, then to some extent it's a sunk cost that doesn't receive any return. And so in many cases, as organizations look to deploy this strategy, they're also looking for their IFM partner to take on the responsibility of the deployment as well as the reporting against that. The last 2 that I want to address are really around how do you look at your infrastructure and assets in such a way that you potentially create either revenue streams or some form of benefit from an asset standpoint. And typically we see this occurring in 2 phases. And really the strategy that we're going to talk about is either deployed against an existing asset or at the time of new construction. What we typically see is ring fencing some form of infrastructure. In many cases, it's the utility infrastructure, and either acquiring that asset in an existing asset and putting it onto some form of balance sheet that sits outside of the organization, such that there's a monetization of the asset and the services that are provided against maintaining that asset, but also, if you will, the outputs against that asset are constructed back to the end user. So when you look at the second slide, when we talk about performance-based infrastructure modeling, that tends to get a bit more of a holistic picture when we're in a situation dealing with new construction. And so, Molly, when you take a look at the next slide, that PBI model is something that we put in place typically in new construction scenarios. And this is, again, not only put in terms of the view of the impact that it has from a capital standpoint, but the long-term operating expenses. So in many cases what we see is a 20 to 30-year form of a lease. So this is, again, not for every asset and certainly not for assets that aren't viewed as long-term holds, but it does give, if you will, the enterprise the ability to enjoy the benefits of taking that out of either the construction budget, but more importantly, the long-term operating budget associated with the facility. Okay. So, Molly, that's, those are, a quick whistle stop, if you will, through the respective strategies. Right? What we'd really ask you to do from a standpoint of taking a look at how organizations can gain some further advantages is something I'd like to spend a couple of minutes on, if that's okay.
Absolutely, absolutely.
So we're going to invite today's webinar attendees to visit the Johnson Controls Global Workplace Solutions webpage. Okay, you can see that listed here on the slide. This material obviously would be available to the attendees for today's conversation. Take a look at the Industry Solutions for Healthcare page. Again, there's a couple of different white papers in terms of specific examples where we've deployed these strategies in more detail. And again, our encouragement is to take a look at how to deploy these strategies, whether it's with Johnson Controls or another provider in the marketplace. But clearly there's a growing trend towards outsourcing of facility management services within healthcare. Some of that's driven upon modeling and blueprinting what has been done in, if you will, peer industries. And we certainly see the increase driven really by some of the macroeconomic pressures that the U.S. healthcare market is facing today. And so the solutions that we've talked about today are in response to those. We think they, in many cases, again, are customized and can be tailored to an individual facility or across an enterprise. And we've really enjoyed really the opportunity today to take you through those and hopefully, again, gain some insight for those that were able to attend.